Okay, Dr. Sandra Billinger, welcome to Tuesdays with Mike. It's a pleasure to have you on.
It's a pleasure to be here, and thank you so much for the invitation.
I'm just absolutely astounded by the work that you've done. And for those in our audience that are not familiar with your work, I'd like to just take a moment, if we could, to introduce and familiarize listeners to both you and your background. And much as though I would normally start with a patient that I'm evaluating for the first time, I'd like for you to just take us through your journey to get to this point in your career. Because if I understand correctly, you've experienced kind of a winding and twisting pathway to becoming a physical therapist and professor, if we just start with that part of the story.
That is true. And yeah, thank you for allowing me to share my journey. So, as you mentioned, I did not take a traditional path. I actually entered the profession as a second career after a serious car accident. I
Okay.
was a dental assistant and I loved my job and was with the same dentist for about 5 years. But at that moment when I had that car accident, it changed my life completely.
Mm.
That moment, it really forced me to completely rebuild. Physically, professionally, and then personally. So I had to go back to school because I couldn't go back to my job as a dental assistant from the injuries that I had. So I had to really make some difficult and intentional decisions about what kind of life I wanted. And so, most important, I think having that experience really shaped how I see rehabilitation and recovery. And I understand what it means to have your trajectory disrupted and rebuild from the ground up. So I always felt like that gave me a really unique perspective from the physical therapist lens and working with people. I understood how hard it is to go through and recovery. In 1 minute, you're fine. And then the next minute, something changes your life. So that period taught me a lot about who I was, resilience, discipline, and then the value of really I had to do a lot of my own sort of rehabilitation. So the value of precision, because when you're rebuilding, I believe that that really matters. So when I eventually entered academia and research, I saw it as a way to really solving problems that matter to real people whose lives have been interrupted, and I could get behind that.
Yeah. Wow, that is significant. Also, as you mentioned, what you gained from it, you talked about gaining empathy, gaining resilience, and not everyone frames a traumatic experience or a crisis in the matter you have. And so I congratulate you for that. And as we continued on in your journey, if I understand correctly, you pivoted again during your undergraduate education. And if you could take just a moment to elaborate on what led to that transformation.
Yeah, so, I'll have to say, Mike, in 1999, I found my academic career in a closet. So during my undergrad work, I knew I really wanted to have this cardiovascular focused career. I really enjoyed exercise prescription and I was starting to work in cardiac rehab. So I really had a strong foundation as I was building my undergrad. And again, I was very deliberate in how I was trying to build all of these pieces. And then the director of the PT program that was hired where I was at, his focus was stroke and exercise. And so my advisor wanted me to help with this project. And I didn't want to deviate from where I was because I was focused, right? And so I do this talk for the love of science, and I always tell people to stay open to opportunities because you just never know where they'll lead you. But I was just like, I don't know if I really want to switch topics because I get pretty focused on things, and I really was enjoying what I was doing. But I did some reading in the literature, started digging in there, and I recognized the impact that exercise could have because of the underlying cardiovascular disease typically
Mhm.
present. But it also made me realize that there was a lot of work to do. And so at
Mhm.
that time in the late, 90s, I mean, very little research was available on exercise post-stroke. At that time it was still not sure if it was good for people. And so here I am working on this exercise project for people post-stroke, and we're using a bike to prescribe exercise, and it was not working. And so I talked to my advisor, and I said, "Look, this isn't working, and I really want to help, but do you have any advice for me?" Because again, I had never worked with stroke, and he said, "If you look in this closet of the exercise phys room, there might be this device that would be helpful to you." And so I thought, well, I'll go explore. And as I'm going through the closet, it's a typical exercise equipment. It's got books on it, TheraBand, clothes, towels. And so I dusted it all off, and it was the recumbent stepper, and it happened to be a new step, a very old one, a T3 model.
Mhm.
And so I started using this device. I saw some potential. And as it started to work and kind of help problem solve the barriers for mobility deficits in upper extremity or lower extremity. And then I realized, wow, this works for exercise, but we can't dose what we can't measure. And so I really started to change my focus and really think about how do we develop and validate an exercise test. So when I came to KU in 2002 to do my dual degree in the PT, joint PT PhD program, my mission became clear. I wanted to bring precision to exercise, dosing, and stroke rehab. And some of that started with developing a way to measure fitness and the ability to dose exercise.
Yeah, wow. We're going to get into dosage today. It's certainly a passion of mine, and most anyone in neuro rehab, cardiovascular, musculoskeletal, orthopedic, sports, pediatric, pelvic health, and the list goes on. We're going to talk about this, and I'm so pleased that you accidentally found your second career in a closet, because dosage and prescription and precision, all of those have a moment in time now that really is coming to fruition. So we'll definitely get there.
Great.
Now, when an individual looks at the publications that you've had, and you've had many that you've been principal investigator on and participated in, it could be very tempting to be reductionist, to feel that everything you've done has been about aerobic exercise. But I would ask you to summarize just a little bit in terms of those research contributions and interests to this point in your career, because you're really talking about brain health. And I'm excited, just if you would like to elaborate today on your new app, the TBR MS Submax test. And if you want to talk about things that you have published leading to this, or just talk about the app, please, the floor is yours on that.
Wow, all right. So let's begin with the aerobic exercise and piece on there. And I think on the surface, if you look at my publication profile, it may look like, oh, it's exercise, aerobic exercise research, but I feel like the deeper theme has constantly been for me measurement and mechanism.
Okay.
Again, I try to use exercise in a way that's not just, well, go out and do some exercise or go walk. It's more than that for me. I'm really grounded in that cardiovascular research, and I know it well as I've read that, and that was where my experience was going to be, and how they dosed it and cardiac rehab. Like I really understood those foundational principles. And I really wanted to apply that in stroke. And that was just a real important piece for me. So I've really sat it and been interested in a little bit of this cross section of how cardiovascular physiology interacts with stroke recovery, the brain, and then as you talked about, evolving into brain health, Alzheimer's prevention, I think has been really important when we think about aging and dementia risk and that area. So I do think that early on, I realized that we were really prescribing, we really were not prescribing exercise clearly with intensity or understanding its biological impact. But I
Mhm.
think we have evolved a lot over time. And I think that's an important piece. And when I give a lot of talks, I also try to preface this as, we're a young kind of research standpoint. We've only really accepted exercise probably about 2006, 7 and 8 forward. I mean, it hasn't been a long time when you look at cardiovascular since the 1960s, maybe even earlier than that. So we have room to explore, and I really think that this is an important area of research, exercise for neuroplasticity. So I would say, the common thread across all of it is precision. I'm trying to figure out how do we best dose exercise, understanding some mechanisms behind neuroplasticity. I think we've just scratched the surface and we're looking for things, but we actually have some exciting research and trajectories coming out, as a field. We're all trying to find some answers about that. But the other really critical point of my research, Mike, that I'd like to share is that, it's not just about me sitting in a lab coming up with questions.
Mm,
I want to make it something that's clinically feasible and meaningful for
mhm.
our field.
Yeah.
And so I
Yeah.
think, that then takes me into the app.
Yeah, that's beautiful. And I think the consideration of measurement and mechanism.
Mhm.
And I love the fact that you put the two of those together because you're talking about accountability and you're trying to elevate the profession to a point where, we all clamor about reimbursement and we're doing a great job and we really need to be paid. And I actually was interviewed on a podcast at 5 o'clock this morning, talking about the same thing. It was the No Stroke podcast. And they said, well, what are we going to do about this dilemma of reimbursement? And I said, we need to go back and make certain that we can prove that we're making an objective, irrefutable difference. And when you talk about measurement, you're talking about that. And when you talk about mechanism, I love the fact that you said we're just now scratching the surface on neuroplasticity because you can be thinking, let's say 12 years ago, well, it's all about BDNF. Then it's all about dopamine. And it's all about making new connections and diverse. And everything's got to be, task specific practice. If you go back to the 3-step, which I helped to organize in 2005. Well, therapeutic exercise is having a say about that. And we know that it's neuroplasticity is more than just about BDNF and really that understanding of the mechanisms behind it. You're doing a beautiful job of helping us do more than scratch the surface. If you feel like the app has something to say or you want to lean in a little bit more about the app, I know that our audience would be very inclined to hear what you're bringing to us there.
Yeah, thank you. And I'd just like to say, I agree 100%. Again, when you brought up the point about, looking at my career and really exercise focused and maybe being reductionist, exercise, I think, again, I'll go back. I think as a field, we have to be deliberate and intentional about how we use exercise in our clinical practice.
Yes.
I always hear, well, I put them on this and then I'll, on this bike or this stepper, and I just have people kind of warm up. But we can be intentional about that and we can help that patient make gains because if we can build endurance, they're going to be able to do the gait training and the other activities. And I think this leads very nicely. And I really am grateful that you're giving me a platform to share my app because about the app, I unveiled it a little bit and gave a teaser at CSM. And it was so fun to see the audience clapping when I unveiled it because it's something that's really needed in the field. So when I came to KU, I really wanted to develop these exercise tests. And the first one was, I had to develop in young, healthy people and validate it and show that it was reliable and meaningful for me to even move forward. And so once we finished that test and or that study and showed that it was feasible, and we called it the TBRS max test or TBRS exercise test. But then it had to be modified for aging adults, people with disabilities, because that's where I thought we could make the most impact. Young, healthy people are running or bikes, they're probably not on a stepper device. But I really wanted to help everybody. So I was, very gung-ho on exercise testing for everybody. We need to be precise. And then I was like, yeah, that's not going to work in clinical practice. We can't, it's not prescribed. If you don't have access to a metabolic card or a stress test or ECG, specialized people, exercise physiologists who are running it, cardiology. That is just not feasible. So I went back to the drawing board and I said, you know what? We're going to develop a submax test because we could do this in clinical practice, right? We
Okay.
do the 6-minute walk test. It measures endurance, walking endurance. So I really thought hard about it. And I didn't want to recreate the wheel. So when we published these data in 2012, we actually just modified a very popular cycle protocol called the YMCA protocol. And so we
Okay.
just modified it for a stepper device and put it together. And the one thing that the YMCA protocol doesn't do is give you a VO2 peak, an estimated measurement for that. And so we built an equation, tested it in older adults and then in stroke, and it worked
Mhm.
really, really well. And so I really wanted to give this to clinicians and to practitioners, anybody who was willing to use it. I was like, all right, I put together a video, how to run the test. We put, sheets, data collection sheets so that people could use them. And then we developed the Excel sheet so that people could start, using the equation very easily. And that
Mhm.
was fine. But let's be realistic. After COVID, I was like, okay, we have got to get beyond Excel sheets and grow this. So then we developed QR codes. I had taught in Singapore, and before I wanted to go over there, I wanted an easier way to teach and to show how this can be used. They're actually integrating it into their inpatient rehabilitation, and the physios and the teams and the neurologists and physiatrists are just really on board with this. They really want to make a difference and an impact in chronic disease. And so I brought the QR codes and they loved it. And they're like, can you just make an app? So so I was like, okay, I came back and I started working on the drawing board. I, kind of registered a product here at KU and worked with our teams here to go through that process. And I had a study team or a team member who helped me build the app and put it all together. And so I unveiled a few, pictures, but the neat thing about this app is it'll all be on your phone. It'll be right at, point of care that you can do. Um, Everything will, like I said, be in the app. And then we actually have pulled in a data fitness calculator where when you end the test, you'll get their fitness level and where they are relative to their age and sex matched
Mhm.
peers. But
Mhm.
also, again, it will create a PDF that if you wanted to give it to the patient or you wanted to put it in their medical record, you'd be able to do that. It would be de-identified and everything. You'd have
Yeah.
to, do however you want to name it, but it would all be de-identified. So we're really excited. And, in my lab meeting earlier today, I used the analogy. I said, now I kind of understand when Taylor Swift said she was so excited to acquire all of her music back, and she just was so excited. I mean, I started down this road in like the late 90s, early 2000s. So, like, this has been a real joy to think that this is going to be something that's going to be available and can make an impact. I've had
Wow.
so many comments and emails and posts on LinkedIn when I shared the app icon for what's coming, and it just
Yeah.
really brings me a lot of joy to have that.
That's great. It brings you joy. It brings you full circle. We all know you're not done yet, but it helps to kind of complete that, pull the new step out of the closet moment, as it were. Talking about grabbing all your music and your anthology together and putting it into an app. This is the why
It
you've been
is.
doing this. And really, for individuals that are listening, only if I understand correctly, you're giving clinicians without the cardiac cart, ECG, and etc., the opportunity to reliably predict VO2 using a safe submaximal test to predict it. That also does something for the participant, patient, consumer, customer, because they get an opportunity to see where they are, benchmark, potentially gamify. Am I improving? Coming back to accountability, is this therapy that you're prescribing working for me? and compelling the practitioner to deliver a significant enough dosage to make a difference.
Exactly. I
There's
couldn't
so
have
many
said that
layers
better.
to what you've got.
I,
It's
yeah, you summarized that well. I could not have said that better. Yeah, that is a really nice summary. It is definitely a way to give clinicians a tool to help guide that practice. And again, measurement, right? We're at that
yeah,
measurement space. Yeah.
yeah. Do you want to lean into the mechanism side of things a little bit more? I just want to permit you, because we will have some individuals listening to this that are persons that are still recovering from stroke. We all know that secondary prevention is a huge part of it. 800,000 people per year in the United States are going to endure a stroke. Hypertension, high, lipids, cholesterol panels, blood glucose. Those are things that are responsive to therapeutic exercise. We all know you could do that. But what else do you want to say about the benefit of therapeutic exercise in brain health and mechanisms there? What would you like to lean into there?
So, is the question about what would I tell somebody that's had a stroke related to that?
I think that's probably the best thing. Thank you for
Okay.
reframing. Yeah.
Yeah, I just want to make sure I'm on the right question here. And so, and making sure I understood the question. So
Yeah.
when I talk to, a person, I always want to start with possibility.
Yeah.
Like my most important message is always, thinking about the possibility of what you can do and how do we get there. And again, I think some people want to know, well, how is this going to help me? Right? Or it's just exercise, or yeah, right? I think those things are important. And I really want to, share if there are listeners that have had a stroke that, again, back when I started, we thought the brain was static, and we know that it's not now. And we know that the brain and the body respond to challenge. And
Mm-hmm.
exercise, if we're talking about that, is one tool to really get from point A to point B. And so I try to
Mm-hmm.
explain, that the importance, and we have some really great graphs and data that where we've used transcranial Doppler ultrasound to measure blood flow at rest and then what it looks like at exercise. And we know that increased blood flow to the brain is good. It improves vascular health, but also supports conditions for neuroplasticity. And so when I
Mm-hmm.
show these graphs, a lot of times if I do community talks, we have data that shows, low intensity exercise and moderate. And when we dose it, again, that exercise, that low intensity, it's about the pace that you're at when you walk across the room or you're doing groceries. So it's meaningful to them in their life. And you can see how blood flow does change with low intensity exercise above
Mm-hmm.
rest. And
Yeah.
then, again, if you go a little bit higher and a little bit higher, um, not quite into vigorous intensity, but in those thresholds of moderate intensity, you can see that brain blood flow goes up. And so again, if we want to think about brain health and stroke recovery, all doing all of those things is really good for that. Most of the time, it resonates with people, and especially if they're looking at studies. But again, these are people who are seeking opportunities. And so, sometimes I get emails and opportunities to speak to people post-stroke in communities. And so, in that respect, I do think that the most important question is, knowing like what you did with me, asking the person about their history, where they're at, what they're interested in, because you have to meet them where they are. And the best exercise is the one they're going to do. You can
Yeah.
prescribe all you want with precision, but if they're not willing to do it, we have to be able to think on our feet and still figure out measurement and mechanism with and meet that person where they're at and what they're willing to do. So yeah,
Yeah.
that's what I think about when I'm talking to people post stroke. Yeah.
So you've done an exceptional job of guiding us through your journey, helping us see where you've come, how you've come. It wasn't planned out, wasn't necessarily predicted, but it has certainly been beneficial to the profession. You've helped us to understand, measurement and mechanisms. We just got through talking about cerebral blood flow potentially being a very powerful mechanism that can support neuroplasticity. I won't put words into your mouth to say that it can potentially mitigate degenerative diseases. You can consider that for a moment. Let's talk a little bit about prevention. And in our next question now, we talked about mechanism there, and we were speaking toward a person or provider that was working in recovering from stroke. Where do you see the anthology of your work contributing to preventative health? Certainly, the cerebral blood flow is still there for you, but if there's anything you'd like to expand on and conditions that you'd like to tag into Alzheimer's, other degenerative diseases, and stroke prevention or brain health prevention, feel free to elaborate in the prevention and wellness models of your work.
Sure. So if I'll stay in the stroke lane for just a moment here, and if I start with this premise, stroke is fundamentally a vascular event. And
Mm.
so when we think about that underlying pathology and physiology, it has to be, I feel, part of that recovery strategy and not an afterthought. And so I know we've talked a lot about, exercise, and one of the areas that we're looking at is high intensity interval training. And I just want to be clear, when I think of HIT and I think of HIIT,
Yes.
this is really based and grounded in the exercise physiology literature of specified exercise duration. So again, maybe 1 minute on, 1 minute off, 3 minutes on, 2 minutes off.
Mhm.
And then you have your recovery bout. And so that might be a little bit different than high intensity gait training, where people are walking really fast or getting their steps in or doing these high intensive activities. And then they might stop and rest for 10 minutes, 5 minutes. It's really dependent on the therapist and what they see. But when we dose and exercise studies for HIT, we really have these defined intervals. And so I think for that, I like to understand it as it's, looking at the things that we measure, which is gait or walking endurance, but also thinking about measures of vascular health. So whether we're looking at arterial stiffness or cerebral blood flow, neuroplasticity, that all of these things tie together. I've really been passionate and started talking a lot more about heart health for brain health and thinking about those things. And so if we believe in neuroplasticity, then we have to believe in that the dose and the intensity are really important and that stimulus matters. And underdosing is not just neutral, it limits adaptation. So I kind of like to just put that out there for food for thought. Some people might disagree with me, but I really just want to throw that out there and have clinicians and healthcare professionals really think about that and be intentional, because I think it's important. In the preventative space, again, I think there's a lot to think about with exercise, and just being active and moving, and thinking about how do we as clinicians be that first step after, in this space, let's say stroke, because they don't know what to do after stroke. And we just finished a study, where people commented. We did an objective measure of their exercise satisfaction.
Mhm.
But the quotes from people were just moving. And I'll leave you with this one.
Sure.
And that was, this lady said, the stroke stole my body from me. But what I've learned about exercise and how to move it, I've gained some of that back. This was
Wow.
powerful for me. And I mean, I just, felt so moved by her, like not understanding what the potential was for her for preventative health. And, we even got some pictures of somebody doing some interval exercise, and they sent us their heart rates. I mean, they're trying, they're doing it. So again, if we want people to really buy into secondary stroke prevention, we have to be deliberate, intentional. Measurement and dosing is really important to lead that. So that's, in the stroke space.
Yeah, that's excellent. And I'm assuming, please correct me if I'm wrong, that the TBRS will help to real time give the clinician patient team an opportunity to ensure that the dose is worthy. Is that correct? Can it do that on a real-time basis?
It definitely can. I think that is something that, it definitely will do.
Hmm.
I think the importance of having that measurement can do it real time. So,
Yeah.
I'll give you an example. Again, something that I'm really excited about and stay tuned for is we just finished the trial that we were just finishing that I shared what the quote came from. We did this is recumbent stepper and we did high intensity interval training compared to mixed. And I know it's been done in treadmill training and walking, but very little evidence is available on a seated stepper. And so we want to look at walking. So again, if we
Hmm.
can increase people's endurance, can we see improvements in walking?
Hmm.
Um, the outcome assessor was blinded. We did not tell the person what group they were in. So
Okay.
they don't know anything about interval, continuous exercise. We never used the words HIT or MICT, and we didn't tell them our study hypothesis. So they
Wow.
really had no idea what they were doing. And we have enough studies going on in the lab on treadmills and steppers and all sorts of other things that, they might know, hey, I did this exercise all the time, or I did this start and stop exercise. But again, they don't know the questions, so there's no
Right.
expectancy bias as to what they're going to get. And so I think this is
Yeah.
going to be really powerful. So we're hoping in the next month to have this submitted. But I think this is something I'm really excited about to understand. And we used a submax test. So this takes the max testing out of it. Nobody has done this to date.
Yeah.
And we show how you can dose exercise, not needing, the physician clearance and ECG, but to do it safely and appropriately, and to
Yeah.
keep your patient safe and to feel good about what you're going to do because you've already done a test and you know that you know what they can do. There's no guessing. You know
Right.
exactly what they can do. So that I'm
Yeah.
really very excited about.
Well, we share your excitement. I personally do as a therapist that still works inpatient rehab. I've been practicing for 35 years. This is groundbreaking to be able to really have that level of measurement that is tied to mechanism as well. So I appreciate what you're doing, and I will benefit also from what you're doing. You've had a decently sized career now, and you've looked at brain health in many different ways. And now it's not directly related to your current studies on stroke, but we discussed that there are other things that people here will be healthy for their brain. So, if I could, just in a lightning round of sorts, pick your brain on a couple of matters that you feel are worthy of investment for a person's brain health. And again, all asterisks and disclaimers appropriate here. You do a great job of staying in your lane. Feel invited to elaborate as you prefer. But if I were to offer a topic or an intervention. Some people call them life hacks, etc. And some of these, I would just ask when you hear me mention that topic, just say whatever comes to mind that is your opinion on these matters as regarding brain health. So
Okay,
we've already covered aerobic exercise nicely. We know you're an advocate
I
there.
am.
Uh, we're going to underscore, bold, italicize, and end with exclamation points. What are your thoughts about sleep regularity, though?
Yeah, I'm gonna have to give Dr. Katie Sangsukan a shout out because she, made me realize how important sleep was for my own personal, benefits. And so I am on the sleep, train along with her and feel like that regularity of sleep is really important. I know I've seen some of your posts and like you want to adapt things and be flexible, but not with sleep. And so, so
You have
so
seen that.
I have. And so I also agree. I think getting regular sleep, going to bed at the same time, waking up at the same time is really good for the body. There's a lot of work around, during sleep That's the clear time when the brain is clearing processes, things that we've done, things that we don't need throughout the day, and getting rid of that in the sleep process. And so a good amount of sleep, I think, is really important for brain health, heart health. It allows that sympathetic nervous system to come down and just really
Point.
relax and just, take time off from our busy days of, exercise or social media or work or whatever you have going in your life, and really just give that your system a time to reset. So I do agree in regularity. Yeah.
Yeah, excellent. Speaking of lymphatic system clearance, etc., we all know that you have been an expert in Alzheimer's disease, published in that realm. Perhaps you'd be willing to weigh in on beta amyloid clearing medications.
Yeah, that's a topic that I'm a little less comfortable in, but I know enough just to dabble. We have a fantastic KU Alzheimer's Disease Research Center. And so, they are testing these medications and working with them. And we've just had some conversations around that. And there are some people who really benefit. The people who are working one-on-one with the families see benefit to that. I think this field is still young. We're still learning a
Yeah.
lot about who it's best for, who benefits when, how early do we give, but certainly, those things are really important. I do know that not everybody can maybe who's on those medications, like we have to think about that if they come in with a stroke, because I don't think you can give TPA with that. That's the recommendation
Right.
right now. So there's a lot of complexity around it. I think it's exciting that we're exploring it, but I still think that there are things we don't know and that we're going to continue to investigate and understand as we have these clinics to help with it. But for families who really have been affected by this disease, it certainly is something that gives possibility and hope.
Mhm. Beautifully answered. Let's move to resistance training. You've done a lot in aerobic. What are your thoughts on resistance training? Not to say that you don't add some resistance within your cycles. Speak to that if you would.
Sure. So I think resistance training is important. I incorporate it into my own routine. I think having, again, sort of keeping your body challenged in different ways, whether it's resistance training, cycling, walking, running, what have you. I think resistance training is important. For stroke, I think that is one area that we're exploring. My colleague, Dr. Ada Tang, and her PhD students, I think they're about ready to publish, if they haven't already, on resistance training and stroke. And that's an area where I've collaborated with a group in Brazil to look at circuit resistant training and what can be done in the clinic. And those are
Mhm,
important things. Again, I think we have to be mindful and thoughtful about how we deliver that and how we translate that to when they go home in the community. Uh,
mhm,
Not everybody wants to go to a gym and be in the same space. And so, what can we do to help people engage in resistance training? Cycle ergometers and also recumbent steppers have a workload associated with them. So,
mm,
while you're doing aerobic exercise, you can also get some resistance in the lower extremity or at all extremities if you're on a stepper. And so those things I think are really good to try to get that to work that into your routine. For aging, I really believe that, resistance training is key. My dad used to always tell me that, the stronger athlete is the better athlete. And I feel like as we age, if you have muscle mass and you're not losing but trying to preserve, I think that's the better ager. You'll
yeah.
be a little bit stronger and to be able to do things. And I'm really excited for my colleague, Dr. Eric Vidoni, who's doing a trial for older adults that's aerobic exercise, resistance exercise. The control group is stretching and toning, and then there's a combined group with resistance training and aerobic exercise to
Wow.
see which affect brain health, which are what is going to be the best dose. They're also doing a nice job of capturing any, adverse events. And so we have to look at that to see, how do they handle resistance training? Um, because we also need to be thoughtful about dose with that as well. And so I'm excited for some of these things to start coming out in this space.
Yeah. You have absolutely blown me away, and you've exceeded my very high expectations because I had one more question that was posed to talk about dosage and the fact that we're not hitting precision rehabilitation, which I believe starts with person, but has to have a fundamental basis on a mechanism and has to have a measurement so that we can determine what that prescription is ongoing and how to advance it. But you've already told us now about the TDRS submaximal test and what your work is doing, not that it's the only thing,
Correct.
to help to elevate precision dosage. So I want to leave to you an opportunity to address dosage one more time, precision rehab one more time, or to close with any advice that you have for people seeking rehabilitation as a profession. Whichever one of those questions that you want to dive and lean further into to bring us toward a close.
Well, I will start with dosing because I think that is important. And I think broadly speaking in rehabilitation and wellness, it's remained fairly ambiguous. I don't think we
Mm,
have that defined.
yes.
And I'll just kind of share a few things. So, in pharmacology or in medicine, we never take some medicine. Here's some medicine, go take this. We specify milligrams, frequency, dose. And I think we can also use that FIT principle, frequency, intensity, time, and type, with exercise to help people with exercise in stroke recovery or in aging or whatever clients you're working with. And the reason I say that, and again, it's helpful to start with the person and understand where they are, what they're willing to do, and then dose appropriately and push them and show them what is possible. Far too often, I will say there's two viewpoints. People sometimes have a view of exercise that they may not understand what if they've never exercised, they may not have the best impression of exercise. And again, I think it means a lot of things to a different people. So you have to talk to them and understand where they're at and what their understanding is. I've also been at a couple of conferences and presentations where I hear, well, people don't exercise. They didn't before their stroke. They might not now. But let's not go there first. Let's talk to the person and get that information so that we can understand what they're willing to do. And instead of saying, here, go exercise, that's not helpful. Let's give them some prescription on that. And so I think that
Yeah.
is something that we really have to do. But I will start with the researchers too. We
Mm.
have to publish our data in a way that covers frequency, intensity, time, and type. And that's what we're going to do in this study that I was sharing. We call it the FAST trial, Fitness After Stroke. We are going to be very transparent about our dose and what worked and what didn't in this because we have to get the message to the clinicians to really be able to understand how to do it, what's safe, what's effective, and what can they adapt that it can be realistically implemented. And so I think this will help sort of provide a cultural shift towards dose as a central theme and not optional.
You're going to appreciate this, I hope. Uh,
Okay.
so I'm writing an article right now with my friend Dr. Beth Fisher. You likely know Beth, USC. And
Mhm.
we are adding principles of neuroplasticity onto the 2008 Kleiman Jones. And
Nice.
my principle number 11, first one after their 10, is dosage matters.
Yeah.
And a lot of people think, well, they've already talked about dosage. Kleiman Jones did a great job. That article is magnanimous. Most articles don't have that, type of longevity and that much reinforcement in the principles that they suggested.
Yeah.
But what's not been done which I again believe that you'll agree with, is that intensity matters, principle number 5, doesn't give us a dosage. Repetitions matter, doesn't give us a dosage. We need frequency, intensity, time type, potentially volume and progression along with that, so that we can be the scientists that deliver this, or the pharmacist of exercise, if you prefer, so that we're not doing exactly as you started this answer. We don't give you some medicine, we give you the right medicine for your condition and for your preferences and your current fitness level. Dosage matters.
It does. It really does. I'm just going to share this little piece with you too. But dosage is so important that the NINDS and StrokeNet, I'm leading up a task force on dosing after stroke. We have some people on the task force that are, are big in this space and huge. And so we're trying to answer this question and have a conference down the road in 2027. And we don't know what that's going to look like. We're just getting started. But this matters, right? We have to answer these questions. And there's so much unknown across the whole body, not just upper extremity, not just lower extremity, but aphasia, cognition. All of this really matters for stroke recovery. And so stay tuned. There is more coming in this space as we really try to evolve and understand these questions.
Yeah, amazing. I could extend this for hours more. Why does the arm not recover as well as the leg? Cognition. Wait, we can achieve neuroplasticity of cognition. Dr. Sandra Billinger, you are a treasure. You're on the cutting edge. I firmly endorse and believe you're also on the correct pathway. You're guiding us in that pathway. And I've been amazed at what you've revealed for us today. I have to tell you, I am thankful for the pivots that you've taken to bring you to where you are. I'm sorry for what you've gone through in terms of your career shifts, car accident, to get us there. But I appreciate your perspective to say this gave me an opportunity. And we're so thankful that those opportunities were received well and you actualized and optimized yourself through those. Thank you for the contributions to our profession, the patients that we serve. I know you're a fellow of the American Heart Association, and that's not typical for a physical therapist as well. So I just want to acknowledge that your presence here on the podcast is impactful. So thank you for your work.
You're very welcome. And that was a very kind summary, and I really appreciate the sentiments and everything. We are really excited for what's coming, and again, we really hope to make an impact down the path and everything. But it does take a village. It's going to take all of us to get this moving. So I really appreciate the opportunity, Mike. Thank you so much.
Yes, thank you.